Good afternoon and welcome to our CT STI clinical management series, Connecting for Sexual Health. I think for those who are joining us since last 2 weeks, they probably know the deal by now, but since some people might be new, I will just do my housekeeping introduction as usual. So my name is Amit Achra. I am the infectious disease faculty at Yale School of Medicine. And it is my pleasure to welcome you all to the Connecting for Sexual Health series, which we have been having on every Thursdays in the month of May. And today is a third one, which you will hear about shortly. Series is planned by the CT Department of Health, Public Health STD Control Program, as well as the Urethritis STD HIV Prevention Training Center. And it has, exciting line of topics yet to come as well as today. So don't lose your enthusiasm yet. This series is one of the many educational initiatives that we have planned in response to the rising STI epidemic, both locally and internationally. And we hope this educational initiative will improve your knowledge and confidence in handling the common STIs and common syndromes as we see more of them in literally any clinical setting that you might be in. So housekeeping, as a reminder, you may type your questions in the chat box as well as you can raise your hand at the end of the talk. We will address questions at the end. The CME details will also be posted at the end of the presentation. So do hang on till the very end. And finally, before we begin, I also want to remind people of this excellent resource, which I hope by now all of you know, is STD Clinical Consultation Network. And so basically, this is a platform which is supported by CDC. It's also in their guidelines app linked to it. And if you are a clinician anywhere in any setting, and if you have a question about a case, you can run it by experts. We try to get back to you very shortly in a couple of days, and if needed, we can escalate to higher level testing and so forth. So we can help you connect to CDC as well if you need to. So please do use this resource. This is free, no obligations, and we really look forward to your questions there. Okay, so I'll stop sharing my slides and I will now introduce our speaker, Dr. Katherine Shu, or Kathy Shu. So Kathy, before I give her formal introduction, I should say that we are, I've been working with her now for about 3 years now, 2 years, and she really is a renowned expert in the STIs and a mentor to many of the young faculty like me. So it is truly my honor to introduce her for this talk. Her official bio is big, but I will try to be brief. She is a medical director of the Division of STD Prevention and HIV/AIDS Surveillance Program at the Massachusetts Department of Public Health. And she's also the director of Silveratile STD/HIV Prevention Training Center, which is one of the 8 STD clinical training centers funded by the CDC. She's also professor of pediatrics and an attending physician in pediatric infectious diseases at Boston University Medical Center. She has, medicine from Brown, a residency from Columbia in New York, as well as a fellowship in pediatric ID from Boston University. She's also completed multiple other fellowships related to the STD, including a Master of Public Health. She is a recipient of Massachusetts ID Society's Edward Cass Award for Clinical Excellence during fellowship. She's also board certified in pediatrics and PDID, and also a fellow of American Academy of Pediatrics. She also sits on multiple scientific committees and reviews and editorial services to multiple high-impact journals. So we really are in for a treat hearing from Kathy Shu. And you can take it away, Dr. Shu.
All right. Dr. Achra, thank you so much for that kind introduction. I can't wait to turn the tables on you in a couple of weeks. And thank you for being the co-director of this excellent, amazing Connecticut series that we've been doing with the Department of Public Health. Behind the scenes, Arlene Lewis and many others have been working with us to pull together this Connecticut relevant STI series. So it'll be great to showcase some of that today. Can you all hear me okay? And can you see the slides well?
Yes.
Terrific. All right, so today, my topic du jour for this afternoon's talk, this noon Thursday, is earthquakes in the management of urethritis, gonorrhea, chlamydia, and mycoplasma. Oh my. With that alliteration, we will get the show on the road. If I can forward my slides, that is a question. I have a couple of disclosures. I briefly consulted for Talus Biomedical Corporation, which no longer exists in that form anymore. Please let that not be a lesson not to consult with me. But that was last July, so I have to still disclose that I was working with a company related to point of care diagnostic testing that was hoped to be rolled out in OBGYN settings. I do intend today to discuss some unapproved and investigative uses of commercial products and devices in my presentation, namely some off-label uses of antibiotics for the purposes of Mycoplasma genitalium treatment. And when that comes up, I will point this out again. The objectives for today's talk are to discuss the management of urethritis, as we are in 2024, and distinguish some relevant updates to STI epidemiology as they pertain to clinical care, and provide and review those clinical resources to access expert guidance on STD management at the point of care. So to get things started for today, let's think through a basic case of a 22-year-old cisgender man who presents with 3 days of dysuria and penile discharge. He has sex with cisgender women and cisgender men. Plant that in your thinking. The opening question is, what evaluation, specimen types, and tests would you recommend, and how would you treat him? If any of you have access to the chat right now, which unfortunately I have buried on my single screen that I'm working on today, please feel free to go ahead and enter some thoughts. I'll give you about a minute or a little less. A minute feels very long on Zoom.
Yeah, I'll monitor the chat. I can speak out the replies.
Thank you. Amit, have any great ideas come in from our audience yet today?
Coming in now. Okay, so I think they're processing. So yeah, so cis man with symptoms and also sexually active with women and men. And the first answer is, yeah, GCCT testing with empiric treatment. Okay, that's interesting thought. Yep.
Yep.
Anyone else? Okay, more extensive. Sorry.
Yeah, go ahead. Tell me.
More extensive one is the doing multiple STI testing, so gonorrhea, chlamydia, trichomonas, HIV, Hep C screening, and then empiric treatment for GCCT.
Great. I think those are great. It's just a perfect starting point for a base case. And many of you practice in different settings. The invitation to our noon series actually went out to every licensed clinician in the state of Connecticut. So it's conceivable that you practice in an STI clinic setting and you see more specialized cases, or you practice in a primary care setting and you well know what access to testing and point of care materials you have. But undoubtedly, the starting point for every one of us is objective evidence of urethritis. In this scenario, it's probably wise to embark on a journey of diagnostic stewardship in order to reduce unnecessary testing. And the first step is still to confirm, not that just that your patient actually states that they overtly have the discharge. We never disbelieve that. It would be better also to document it in some way with objective evidence. So what is objective evidence in 2024? Guess what? Any of you who have been practicing for the last 5, 10, 15, 20 years hasn't changed. Most of us no longer have access to microscopy to do a gram stain on penile secretions. or a gentian violet stain, or a methylene blue stain. It doesn't matter. We can't stain anything at the point of care anymore. So to document objective evidence of urethritis, you can either do it through the vision of mucoid, mucopurulent, or purulent discharge on exam. You examine the penis, you squeeze the shaft, and you identify a droplet of extra discharge. Even a droplet is unusual. That's not normal. That counts. Or could you take objective evidence as the person reports on their underwear? They have had secretions which are not normal for them. I have been known to do that. It would be preferable to actually see it on exam, but sometimes you just don't get it. If you don't have the opportunity to actually visualize this, you have a backup. Either the positive leukocyte esterase test on a first void urine being the technical term for not a clean catch. We're not talking morning urine. You don't have to punish your patient by making them get up even earlier to come see you. No, you can just get the first void. Having not urinated in the previous hour, probably it's sufficient enough to be a sensitive test for objective evidence of urethritis, that itis, that inflammation that we're looking for on exam. Or microscopic examination of the sediment from a spun first void urine, demonstrating greater than or equal to 10 white blood cells per high-powered field in a concentrated specimen. The way to obtain that for many of us in 2024 is to send a urine analysis to the lab and have them spin it down and do it for us. Most of us no longer have the capability to spin down a fresh urine specimen and do it ourselves anymore. So those are your three ways to document objective evidence of urethritis. But assuming that's done, you then proceed along your way and you go ahead, send gonorrhea and chlamydia testing, just as a couple of you suggested, because those are the leading two pathogens that could lead to urethritis in a 22-year-old bisexual cisgender man. Okay. Let's start with gonorrhea, though. If this were gonorrhea, we are headed into an era where you won't always be able to count on cephalosporins. So where am I going with this? Well, the first thing is to point out that gonorrhea is concentrated in specific populations. However, and these populations are youth and young adults, the southern US, the darker cells and counties in this map, and also there's evidence that it's concentrated more in non-white populations because of the circulation within the sexual networks within those populations that often have many disparities. And this is yet another one of the glaring disparities that exists. It likely is also from disparities in access to care for screening. So that results in more circulation in non-white populations. And that's demonstrated in the top graphic here. CDC's gotten a little bit better about displaying how race and Hispanic ethnicity are some of the leading indicators for STIs. If this is the percent of the total US population, notice that the percent of reported cases of gonorrhea is greater in non-white population. But the key point from all of these graphics, yes, youth and young adults, yes, southern US, yes, non-white populations, but look beyond those and notice that no one and nowhere is exempt. What am I talking about? Well, here are the Connecticut numbers. And what I'm trying to show you on this graphic, which dates back to the way we've been tracking both syphilis and gonorrhea, basically back to 1990, is that we are slowly returning to almost 1980s levels of STIs, which in many of our careers, none of us have seen this volume of case reporting or this volume of disease. Connecticut is no exception to what the US in general is seeing. And yes, there are occasional changes year to year and year to year variability, but focus on the overall shape of this curve. And I think no one in the room would be blinded by the fact that it is, in fact, a U-shaped curve and a return to 1980s levels. What is that going to result in? An increase in all of our base case numbers dictates an increase in complex disease. So that means, as clinicians on the front lines, all of us will be seeing more symptomatic urethritis, symptomatic cervicitis, and breakthrough cases of neonatal conjunctivitis from things like gonorrhea and chlamydia, because if that ribbon of iloticin ointment works 95% of the time, but suddenly you've gone from 10 cases of exposure to 100 cases of exposure, occasionally you will see failures of iloticin ointment. You will see the potential for more complex dissemination from the local mucosal surface, the pink part where the gonorrhea may have been the portal of entry was the cervix, but it eventually can ascend. And these are the violin string adhesions pictured in a recent case of PID that's linking the liver capsule and the diaphragm. You will see more cases of disseminated gonococcal infection because out of every 100 cases of gonorrhea, about 1 to 3% of them disseminate. If they are silent for long enough, they can invade, the patient can develop bacteremia and seed another part of the body. And these are some of the recent examples, perhaps a disseminated gonococcal infection that's the traditional tenosynovitis or around the joint space of the small joints of the hand, or it could be something far more rapacious and more difficult to treat, like a gonococcal endocarditis, pictured in the lower two, or it could be a very indolent kind of infection, a patient who presented over the course of a month or so with a slowly enlarging calf. And everyone thought this might be a bruise. The person was a runner. Turned out when they took the fluid to measure what it actually was and stained it, it had gram-negative intracellular dipococci. And this was, in fact, a case of disseminated gonorrhea that may have taken roost in that person's calf because that person's calf had been bruised. Any bruised area or injured area of the body often represents a great area for a pathogen to come to roost because they love sitting around in the blood or the bruising. That may have been the incident or inciting moment, but the inciting moment was also the fact when the patient was told that this was gonorrhea, he said, well, it is true. About 2 months ago, before all of this started, before I went on a long run, I had oral sex. Never documented that his oropharynx was still co-carrying it, but that may have been the portal of entry. You on the front lines are going to see and hear of more and more cases of unusual presentations of typical disease, or cases like in the pandemic, when somebody sits on their infections for long enough, gonorrhea can definitely locally invade. As a penile abscess, it can locally seed. You can distribute it and auto-inoculate it to your eyes. Yes, it can also locally seed breast or any open tissue or surface tissue where it's distributed. And there have been cases as recently as a couple of months ago of a mastitis that was retrospectively traced to a gonococcal origin. Very unusual presentations because the base case numbers dictate increase in complex or unusual cases. You'll be seeing them in the years to come. Well, why is this also another concern? On a whole nother level, gonorrhea is special amongst the STIs for its ability to evolve drug resistance and our inability to continue to be able to treat it with our existing armamentarium of antibiotics. It has made the list of CDC's list of most concerning pathogens, antibiotic resistance threats, both in 2013 and 2019. I'm going to explain a little bit about how NG evolves resistance and why we care more now in the next few slides. I'm a little tongue-in-cheek here. CDC cares about resistant gonorrhea, so should we. And in fact, they've declared war for many, many years upon this pathogen. It is listed right up there with things like carbapenem-resistant Enterobacteriaceae, C. diff, Candida auris, Acinetobacter, things that hit the headlines. And so does drug-resistant Neisseria gonorrhea. Because it becomes more common in parts of the world, for example, Thailand is now reporting 40% non-susceptibility to cephalosporins, which are traditionally our last line of defense for gonococcal treatment. It has been able, after any antibiotic has been thrown at it, it has been able to evolve resistance away from that particular antibiotic's control. First the sulfa drugs, then the penicillins, then tetracycline, then quinolones. Oh, for the days of quinolones when we could treat with a nice single dose oral drug. Maybe they'll be back. We'll talk about that in a moment. And the first signal of cephalosporin resistance was actually back in 2011, over a decade ago, when Onishi et al. Published this from the Japanese literature. The isolate came from the pharynx of a female commercial sex worker in Kyoto, and that was the first known case of higher level resistance to ceftriaxone. This signal of decreased cephalosporin susceptibility has continued over the ensuing 15 years. How does this happen? Transformation plays the key role. Gonorrhea actually acquires resistance determinants from other bacteria, probably in the backs of people's throats. Some of you may have heard me make this analogy before. Gonorrhea, the organism, is trading these resistance determinants, sort of having sex with other bacteria in the backs of people's throats. And pharyngeal gonorrhea may act as a reservoir where asymptomatic co-colonization with other Neisseria species can occur. But guess what? It doesn't even need to be species specific. It can also trade resistance determinants with things like H. influenzae or E. coli or other bacteria. And the oropharynx is home to many, many pathogens that it can do cross-species conjugal plasmid transfer of resistance determinants. It's that adaptable, unusual amongst the STI family. We, in fact, saw recent evidence of cephalosporin non-susceptibility in Massachusetts, your close cousins, just slightly north and east. The new guidance in Massachusetts, not Connecticut, not other parts of New England, not other parts of the United States, while we are staying firm on the same quantity of ceftriaxone to treat, because the two individuals who were retrospectively traced to have non-susceptible cephalosporin, non-susceptible gonorrhea, it was on a plate. It wasn't in the human. The 500 to 1,000 milligrams of ceftriaxone that were given to each of the patients succeeded in clearing them from infection. However, the guidance in Massachusetts is now to culture so that we can practice our culture ability, because we may need to go backwards before we have molecular tests of resistance. And the guidance in Massachusetts has now been, let's do a better job of documenting that our drugs are actually still working. Please do a test of cure at any site, not just the pharynx, but 14 days later, do a test of cure at any site that was previously positive. And we are going to try to spare cephalosporin for the partners who really need it, who are documented to have gonorrhea also. It turns out when you do a look back in 60 days of somebody who's gonorrhea infected, probably somewhere around 40 to 60% of their partners may not also be infected. Not every one of their partners is also infected and deserves treatment. If we could but find and know and test at 3 sites that they didn't need it or they did need it, it would be a better job of diagnostic stewardship for antimicrobial stewardship. Problems are arising. The last year we've been doing this with Massachusetts clinicians. Don't get me wrong, it hasn't been an easy road. There is significant disagreement. It's yet another reminder that gnats are far more sensitive than culture, and you do have to sit and spend time with the patients to explain why one result is positive and one result is negative, but you're going to believe the positive. You're going to retreat it because gnats are much more sensitive. And this is just a collective call that preparing for change, resisting resistance is futile to some extent where this pathogen is concerned. But we all have to exercise our capability to tackle it together now. This hit the headlines last year. This situation is both a warning and an opportunity, said my colleague Kathleen Roosevelt, the director of Massachusetts Division of STD Prevention. It's an opportunity for all of us to culture. That was a year ago. What can I tell you since then? I can tell you great news or non-news, which is that since then, through the due diligence of clinicians all around Massachusetts, we've cultured and harvested over 500 isolates of gonorrhea, and there hasn't been a single iota of cephalosporin non-susceptibility since then, circulating in Massachusetts. What does this mean? Does it mean we're not picking it up? Does it mean our cultures aren't working? Some of the time. Definitely true. The time to announce war and try to culture gonorrhea is not the dead of a New England winter. I'll tell you, for all the fact that that patients are plagued by this, by humankind being plagued by the gonococcus, going from intimate contact to intimate contact, one warm mucosal surface to another, hopping from host to host. This bug hates being chilled on the way to the lab. The certain way to make sure your culture will not pick up gonorrhea is to sit it out in your Quest pickup box in the lobby under conditions of a New England winter. It won't grow then. We've definitely identified that through a series of anecdotal reports. Nonetheless, it's useful to know that we haven't picked up any since those original 2 cases. Is this reassuring? We had to do some mathematical modeling work. I'll just give you the bottom line in the interest of time today. After these 2 incident cases of interest in a state with good healthcare access and electronic laboratory reporting, model simulations imply that if no further cases are detected at about 3 months, further undetected infections are unlikely, cumulative disease burden decreases, and the likelihood of strain elimination is high. Those were 2 cases of importation. We're on the lookout for more to come. So what's a clinician to do? It's 2024. Some of you have heard me say this. I'm sorry to say these slides are not updated for the last about a year or 2. There are still new drugs or novel therapeutics coming for gonorrhea. There are some new strategies for antimicrobial stewardship using rapid molecular diagnostics that exist in other parts of the world, but don't even exist here in the US yet. But you'll be on the lookout for them. You'll be ready, clinicians in Connecticut. And there are vaccines under development. So maybe there's a little new news to share there. I shouldn't be so pessimistic. So for name recognition only, for the past few years, I've been saying these so that we collectively can grapple with the fact that we may have to fire up new drugs fairly quickly to treat resistant gonorrhea. Names like solithromycin, an oral fluoroketolide, a quinolone-like agent, but not a quinolone in spite of its name, zoliflodacin, a spiropyrimidine trione, again, similar to quinolone, but not really a quinolone and actually does better job than quinolone, gepotidacin. All 3 drugs, however, in all preliminary studies, do like every other drug used to treat gonorrhea. They succeed better at genital sites, not as well as that pain point for us, the oropharyngeal site. There may be some novel therapeutics coming down the pike. How about monoclonal antibodies? We've learned a lot about them during COVID. There are some that provide rapid and prolonged protection, but way too soon for clinical rollout. Not even available, not even close to prime time. Don't hold your breath. How about rapid molecular diagnostics, preserving our existing drugs, maybe going backwards, but not using culture, which still takes days, even weeks, to get you an answer while your patient is suffering. Maybe there's rapid point of care testing, same day diagnosis, Point of care testing can include not only a detection test for gonorrhea, but whether or not you could go backwards in that individual patient. Maybe 3/4 of the time, that patient may still have a sensitive, quinolone sensitive strain, and you could use an oral drug. How nice would it be to define that? That would be great. Still not available in the United States, but look for it. These resistance guided treatments may be coming in the next year. The third tactic we're all hoping for, really hoping for release of trial information next year. So hopefully next year, in our updates to clinicians next year, we'll have more information. Guess what? There is an existing Neisseria meningitidis vaccine that may have partial efficacy against gonococci. We've known about this since this really good publication, but even slightly before that, it had come to expert attention. But this particular New Zealand study was really well done, and it was a better way of demonstrating it. So I'm going to highlight Pertussis Harris's study. When they rolled out serogroup B vaccine in all comers in New Zealand, essentially as a universal rollout because they had such a terrible time with serogroup B, we don't have that issue in the United States, so we haven't done a universal rollout the way New Zealand did. There was 31% efficacy against gonorrhea in New Zealand. 31%. Ouch. Not very good efficacy. This was thought to be due to outer membrane protein similarities between this particular Neisseria meningitidis vaccine. It's a special brand of the vaccine. You're actually going to have to look at the brand names that you stock in your closets in the future. And this triggered the NIH-sponsored study of meninge group B vaccine, Bexsero, to prevent gonococcal infection, which is now underway, has, I believe, either finished enrollment or has come very close, and we're looking forward to trial results next year. The good news is we wouldn't have to wait too long, because guess what? It's already a licensed meninge B vaccine. The bad news is, as with any other meninge B vaccine, nobody is thinking that its efficacy against gonorrhea is particularly good, nor is it particularly long-lasting. Maybe 2, maybe 5 years. Maybe there'll be hope for the future for other vaccines. Don't hold your breath on this one. Still under science development, research, not even close to prime time. So back to our case. He's a 22-year-old cisgender man who gave me an excuse to discuss where we are with gonorrhea. But he had presented with 3 days of dysuria and penile discharge, and he was bisexual. You had all recommended presumptive treatment for gonorrhea and chlamydia, which was in fact what these clinicians did. Those are the top 2 pathogens. We talked about gonorrhea already. Let's eliminate gonorrhea from the list. What's left to be defeated? Chlamydia trachomatis is the next most common in most populations, almost all patient populations. Mycoplasma genitalium, we'll be talking about that in a moment, is actually quite common, but we've never known about it until recently when FDA approved nucleic acid amplification tests came into being, and there are now licensed tests for this diagnosis. Trichomonas, this depends on the patient population you serve. Once again, trichomonas is one of the diseases and the pathogens that highlight the racial disparities in our country the greatest. It truly disproportionately affects Black and brown populations. Herpes, yes, it's a cause of non-gonococcal urethritis. And meningitis, yes. Meninge doesn't have to just inhabit the oropharynx and invade from there, but it can actually be transferred at times to the urethral environment, undoubtedly through oral sex or salivary exposure. Other bacteria, other viruses, and look at this. The one thing I want you to take home is that even when well-done studies are done with really good research, applied nucleic acid amplification tests, 50% of the time, we don't know why somebody has an itis, an inflammation in their urethral environment that causes them to tell us that it hurts to pee or has mucopurulent, purulent, or mucoid discharge. We just don't know. And we need to be telling our patients we're very imperfect about our diagnostic ability, even in this environment. So let me highlight for a few minutes, and this should be reviewed because I'm pretty sure I talked about it either this year or last year with the Connecticut group, briefly, where we were with chlamydia treatment in the urethral environment. We had good evidence that azithromycin, a single dose, could clear chlamydia infection from the urethral environment. Or shall I rephrase, and the New England Journal of Medicine paper that was published in 2015 that demonstrated that azithromycin was perfectly fine for urogenital chlamydia infection, demonstrated that azithromycin was non-inferior or was imperfect compared to doxycycline, sorry. Statistically, the non-inferiority of azithromycin was not established. It was a double negative. And in every study, when you look back, now that we've been challenged to look back in this era that we spend most of our time treating with doxycycline twice a day for a week, we've gone back and looked at the older studies, and every study pretty much indicates that azithromycin isn't going to do as good a job as a longer course of doxycycline. There was a hint in this original study, but it was still acceptable to use azithromycin. If you only have it in the urethral environment, probably 90+% of the time, 95+% of the time, you can clear it with a single dose of 1 gram of azithromycin. Okay, where are we now? Chlamydia transmission is entirely based on reservoirs that the only way to detect are through screening, accurate screening programs, because patients usually do not present symptomatic. And we've gotten a little fancier about the fact that perhaps swallowed chlamydia infection can transit through the entire GI tract, survive and land in the rectum, basically due to our patients telling us in no uncertain terms, there are patients who only engage in oral sex, no other source of exposure, and yet they have chlamydia in their anal rectal environment. Too many people have come forward with this story for us to disbelieve them entirely and think, maybe it's just that they can't disclose anal sex or anal receptive intercourse. It's stigmatizing. We're no longer sure that that's the only reason to explain rectal chlamydia. In women, for sure, we've always known sex is messy, and what I've always called the dribble back phenomenon is totally true. In somebody who has front hole chlamydia, shall I say that about 2/3 of the time you can document evidence that they have anal rectal chlamydia as well, using NAT testing, not using reported anal intercourse. And I think that this is just a marker that sex is messy, beautiful, glorious, messy in all its ways. So based on this, people started thinking to themselves, maybe we're not doing justice by our patients. We need to do a better job clearing it from all sites, including extragenital sites. Several studies came out, including 2 in men, 2 in women, and all of them essentially said the same. Azithromycin is performing so poorly that a single dose in the context of expected imperfect adherence to doxycycline twice a day for a week, it should still be the recommended treatment for rectal chlamydia in men who have sex with men. That was the first foray because the female studies were not out yet. That statement could be made. We've removed the concern that doxycycline or azithromycin, guess what? Both of them actually trigger a certain amount of GI distress in our patients, probably 1/3 of the time. And we should be preparing our patients for this. And if they don't tolerate the medication, supporting them in other ways, using things like antiemetics, or making sure that the blow is softened at least with a meal. These drugs do not need to be taken, are better tolerated, not on an empty stomach, as many of you have learned. And better is not the enemy of best. It's absolutely okay to send a script to the pharmacy and have the patient pick it up. They usually do execute on that, but none of these drugs are really supposed to be used, except for azithromycin, in pregnancy. So there are still a lot of unanswered questions. They're the same ones I had last year. Nobody has made a lot of forward movement on these issues. It would be great to know if maybe a shorter course of azithromycin rather than a week's worth of doxycycline would be appropriate and could be okay to give to our patients. Still no data or evidence to support this, not recently presented at any of the meetings, so I have nothing new to report there. Do we have other drugs? Would be great. No, still nothing new. And the question about why doxycycline is doing a better job versus azithromycin is still raised. They have very similar mechanisms of action. And this is not due, unlike for gonorrhea, chlamydia is just not that talented an organism, doesn't develop resistance quite as easily. So we don't think it's due to that. Is it due to special strains of chlamydia that are more resistant to treatment by one drug or another? Not to our knowledge when they sequence from research studies that have been done both in men and women. We're left with two theories. Perhaps there are different host microbe interactions. Perhaps there's temporary suppression with single dose azithromycin. One dose that lasts in most bodies, human bodies and human tissues, for about 4 to 5 days may not be enough. Let's go back to our case again. I still have refrained from giving you the answer because the answer, of course, wasn't simple. In this real case, the patient returned negative for trick, returned negative for GC and chlamydia, and the test for MGen was positive. How would you treat him now, and what would you recommend for his recent sex partner? Let me actually start one step back and open it up in the chat again. Those of you who have availability in the chat, have any of you yet wrestled with an MGen case on the front lines in clinical care? It may not have been you who ordered the test. It may have been you who was on the receiving end of a patient coming in, asking you as their primary care provider, what do I do with this test result? I ordered it online, or I went somewhere else and this person told me I have this. What does it mean? Have any of you yet wrestled with this issue? Go ahead and put it in the chat.
Thanks, Dr. Shu. There is a yes here one already. And while people do that, did you test this person upfront, you said, or this was after the initial negative test for GCCT?
Would it be possible for that person to come off mute today?
Yes,
Or
it
put
is
more-
for just one moment.
Okay, thank you so much.
The results came to me.
Okay, did you
Yeah.
order it? Or did the patient
I
bring
did
it?
not, the state lab didn't have the ability, doesn't have the ability to do this one. So the results came to me just for treatment.
Why did you decide to order the test? What compelled you?
That we really couldn't get a hold of the dysuria.
Right.
That was
Persistent
continuing.
dysuria.
Yeah.
Right. Did
Not
you
necessarily discharged, just the pain.
Did you actually have objective evidence either through leukocyte esterase or that amazing spun urine that you'd have to send out to a lab to spin it down?
There were leukes for sure.
Okay.
There were, yeah, but I wouldn't say it was bright purple.
Okay, fair. But you had objective evidence enough. The patient was still in pain, perfectly reasonable. That is the one scenario where many of us would in fact order an MGen test. So thank you so much for coming off mute. Let me move forward.
Thank you.
Here we go. Beautiful job. Diagnostic stewardship leads to antimicrobial stewardship. The main problem with Mycoplasma genitalium, we should really refrain from testing unless it's recurrent non-gonococcal urethritis or cervicitis. We're only at the point where we consider it because it's not as tightly linked to PID and upper genital tract terrible outcomes in women. And asymptomatic screening is absolutely not recommended. Please don't order the test when somebody just asks you for the test. It's one of the times when you as the clinician has to stand firm and say, listen, we don't know what we're doing with MGen at this point, and it's not to be screened for. Why is it happening now? Because there is an FDA-approved genital and urine NAT, and many institutions that are getting MGen tests back are getting it accidentally because the clinician wanted to order a trick test And the only available trick test on a urine sample was a co-test for MGen. That's how a lot of places are getting this result. Why do we not want to know? Essentially, why do we want to duck our head and don't ask, don't know about this? It's because there is so much drug resistance where MGen is concerned. If it is the culprit, it in fact is very difficult to eradicate from any given patient. And we lack some of the better tests. It's better to have resistance-guided therapy through molecular tests that are available in Europe. We don't have them yet in the US. So Mycoplasma genitalium has been shown to be linked in men with urethritis symptoms who were enrolled from STD clinics. More than 1 in 4 of them with urethritis had also Mycoplasma genitalium. Many of them had co-infection with GC and chlamydia, and upon treatment for that, they did better and did not necessarily need their MGen treated. But it is possible that in some cases of recurrent or persistent urethritis, when you've eliminated the other causal pathogens and you're left holding the bag with MGen, you're going to have to think about the following treatment regimen. Start with doxycycline to reduce the bacterial load. This is the current guidance. Expect change in the near future. There are probably going to be more research studies in this important area of trying to figure out how much MGen is truly linked to disease in humans versus just having it be a commensal or an infection, okay? But if you're going to treat it, here's what you're going to try. You're going to try doxycycline times 7 days, and then follow it up with either moxifloxacin or azithromycin. And the choice between those two is often dictated by allergy or dictated by previous exposure. It's pretty much known that if the patient had recent exposure to azithromycin, which often happens, right? Because you've already treated what you thought was either gonorrhea or chlamydia. Sometimes it happens they've already had this. Any previous exposure in the recent past probably means that the patient has an azithromycin resistant strain. So you can always try this regimen because it is safer, has fewer adverse events than using a very broad spectrum quinolone with all the attendant issues that quinolones have. Longer courses of quinolones have been associated with QT interval prolongation. They have been associated with quinolone-associated arthropathies, tendinopathies, other issues. Any of you who have had to use quinolones in your patients for any other reason, for community-acquired pneumonia, for anything else, it is entirely possible that you've already run into some of the adverse events using a very broad spectrum drug like this. So I'm not going to leave you with easy answers like that. This isn't even easy because you basically try this, hope your patient is better, and try not to look again. I'm going to come back to you who was kind enough to come off mute in a moment to ask. But in this particular case that Phil Chan shared with me Friday, 4:30 p.m., called about a male patient with urethritis who tested positive for MGen and has persistent symptoms despite treatment with multiple antibiotic regimens, including everything listed on the previous slide. You suspect resistance. What are you left with? Off-label, and by the way, all of these are off-label uses of things like moxifloxacin, minocycline. Pristinamycin isn't even in this country, but you can obtain it through an extended use authorization. Many of you have used EUAs more liberally during COVID and found out how challenging the paperwork is. Maybe the patient, luckily for you, is going to go to Europe sometime soon. Send a prescription for something like pristinamycin, which is available in Europe, and they do use it to treat MGen. And Lefamulin no longer available, but we still like talking about it. It's not even produced in this country. That company has folded, not been taken over, and it isn't even available yet. So this really leaves you hoping that your patient is not diagnosed with MGen, only using the test in situations where you have persistent recurrent urethritis or cervicitis documented on objective evidence. And let me circle back. The take homes on this one, please don't test anybody who has no symptoms. please refrain from treating individuals who have no symptoms. Please counsel them that the downsides of using antibiotics for long courses outweigh the upsides of trying to eliminate something that we're not even sure is pathogenic in them. There are some exceptions. We haven't even talked about pregnant individuals. Maybe I don't even want to bring that up. That's even more complicated because many of these drugs are not safe to use in pregnancy. This is going to be a very difficult area. FDA approved genital and urine gnats should be tested. If you're going to use anything to diagnose it, don't use anything off label there. There is something at least available on label. And the treatment is doxycycline followed by moxifloxacin, or sometimes people are defaulting to minocycline, as I said. Again, all off-label uses, and we try to not do the sex partners of symptomatic patients treated only if they are positive also on an FDA-approved MGen test. The resources I'll leave you with today, just as a reminder, the app is available. Apple, Android devices, many of you have already downloaded this wonderful governmental product. Just because I'm funded by CDC does not mean that I have to espouse it, but I use it all the time to look up things like your recurrent herpes drug treatment regimen. Which dose of valacyclovir or famciclovir shall I use today? Or how long should I use it for? Great way to look these things up. And now the treatment guidelines app actually links directly to a resource, which is a direct line to all of us who take call, including Dr. Atra, myself, and several other people, including people who shared the slides that I would love to acknowledge today. Our wonderful Ratel PTC faculty are available to help you. Many of you have already used this function, STD-CCN. Send your de-identified case with as much information about the case to get some feedback from one of us, and you'll get an answer within 1 to 5 business days, as quickly as we can. Sometimes we'll triage it even faster. And I'll end there, leaving at least a few minutes for questions. Actually, I'm going to stop share and ask if that person who was kind enough